Do you know about gold?
Gold jewelry? What are you talking about?
Not exactly, not gold jewelry. GOLD is an acronym for Global Initiative for Chronic Obstructive Lung Disease. And there are many representatives from many countries involved in the GOLD network. The purpose of the program is to implement programs for COPD diagnosis, management, and prevention across the globe. So my GOLD packet, I have it here, and it was updated in 2015. So let's take a look at it, okay?
One of my family members have COPD. He has trouble breathing all the time. You think gold can help?
Yeah. See, chronic obstructive pulmonary disease is a major cause of morbidity and mortality throughout the world. Much has been learned about COPD since it's issued its first report, since GOLD issued its first report. But the global strategy for the diagnosis, management, and prevention of COPD in 2001, treatment of COPD is now aimed at immediately relieving and reducing the impact of the symptoms, as well as reducing the risk for future adverse health events such as exacerbations. So these dual goals emphasize the need for clinicians to maintain a focus on both the short-term and the long-term impact of COPD on their patients. A framework for COPD management that matches individualized assessment of the disease to these treatment objectives will better meet each patient's needs.
What is COPD?
That is a good question. COPD, it stands for chronic obstructive pulmonary lung disease. It's a common, preventable, treatable disease. It is characterized by persistent airflow limitation that is usually progressive, and it's associated with the enhanced chronic inflammatory response in the airways and the lung to particles or gases. Exacerbations and they contribute to the overall severity in the individual patients. Now, this definition does not use the terms chronic bronchitis or emphysema, and it excludes asthma. Okay, but the symptoms of COPD include dyspnea, chronic cough, and chronic sputum production. Episodes of acute worsening of these symptoms is called an exacerbation, and they do often occur. Spirometry is required to make a clinical diagnosis of COPD. The presence of a post-bronchodilator where the FEV1% is less than 70% confirms the presence of persistent airflow limitations and thus of COPD. So if the FEV1% in a PFT is less than 70%, it confirms that the patient is diagnosed with COPD.
Okay.
Yeah.
Now, what causes COPD?
What causes COPD? That's a good question too. Worldwide, the most commonly encountered risk factor for COPD is tobacco smoking. But also, outdoor, occupational, and indoor air pollution, they can also result in COPD risk factors. So non-smokers may also develop COPD based off of those attributes if they are exposed to any of that. The genetic risk factor that is best documented is a severe hereditary deficiency of the alpha-1. It provides a model for how other genetic risk factors are thought to contribute to COPD. COPD risk is related to the total burden of the inhaled particles a person encounters over a lifetime. So the tobacco smoke, which includes cigarettes, pipes, cigars, and other types of tobacco smoking that's popular in many countries, as well as the environmental tobacco smoke. The indoor air pollution from the biomass fuel used for cooking and heating in poorly vented dwellings. Occupational dust and chemicals, so the vapors, irritants, and fumes from exposure are sufficiently intense and prolonged, that can also cause some COPD. Outdoor air pollution also contributes to the lungs' total burden of inhaled particles, although it appears to have a relatively small effect in causing COPD, but it could happen. In addition, any factor that affects lung growth during gestation and childhood, such as low birth weight or respiratory infections, has the potential to increase an individual's risk of developing COPD later on in life.
Wow, I had no idea.
Yeah.
I wonder if Ms. Tubbs ever smoked tobacco.
Well, earlier I had mentioned that Ms. Tubbs is well known to our department. She's been a patient here several times over the last few years, and she is a heavy smoker. She has smoked 2 packs a day for 20 years, so that gives her a 40-pack year history of smoking. Part of our smoking cessation protocol is to identify all smokers and encourage them to quit. So we've tried to counsel her several times about smoking cessation during her hospital visits here, but she's not been very receptive to the idea. So since I'm also the department's tobacco cessation counselor, I will review the 5 R's of motivation intervention with her today.
I've heard about the 5 A's of smoking intervention, but not the 5 R's.
Okay. Well, we use clinical practice guidelines from Treating Tobacco Use and Dependence. It's the 2008 update. It recommends the use of 5 R's of motivation for patients who are unwilling to make a quit smoking attempt. And those include relevance, risk, rewards, roadblocks, and repetition. So relevance is to encourage the patient to indicate why quitting is personally relevant to them. Risk, we're going to explain the negative effects of smoking, the long-term and the short-term effects. Rewards, we're going to ask them to identify the personal benefits of them to quit smoking. And roadblocks, we're going to ask them to identify barriers to quit smoking and also try to provide some treatments for those barriers. And repetition, we're going to repeat the 5 R's until they visit a clinic. So if a patient desires to quit and would like to try nicotine replacement therapy, I can recommend several products such as nicotine gum, the lozenges, the nicotine nasal spray, the transdermal patch, a sublingual nicotine tablet, or the nicotine inhaler. If a pharmacological agent is preferred, the bupropion SR, that can be suggested as well.
Wow, I didn't realize that RTs can provide smoking cessation counseling. I can't wait to observe your interaction with Ms. Tubbs. Can I ask you another question?
Absolutely. I love answering questions.